Welcome to the third lecture in this series. Now that you have learned about the anatomy of the secondary lobule, spatial distribution of disease within the lung as a whole, and the general approach to reading chest CT, we can move on to learning about different patterns of disease. In this video, we will focus on reticular patterns of disease. In the reticular pattern, there are too many lines, either as a result of thickening of the interlobular septa or as a result of fibrosis as in honeycombing. Interlobular septal thickening is a type of reticular pattern. Interlobular septal thickening can be seen as linear or polygonal structures occurring at 1 to 2 5-centimeter intervals that correspond to the walls of the secondary lobule. Interlobular septal thickening occurs when fluid, fibrous tissue, or cells cause congestion of the venules, lymphatics, or interstitium at the periphery of the secondary lobule. Smooth, interlobular septal thickening is associated with pulmonary edema, lymphangitic spread of carcinoma, lymphoma, alveolar proteinosis, hemorrhage, or infection. Here we have an example of interlobular septal thickening in a patient with pulmonary edema. Nodular or irregular interlobular septal thickening, also called reticulonodular pattern, is associated with lymphangitic carcinomatosis, lymphoma, sarcoidosis, or pneumoconiosis, like silicosis. Here we have an example of interlobular septal thickening in a patient with lymphangitic carcinomatosis. Intralobular septal thickening is another type of reticular pattern of disease. The intralobular interstitium supports the various structures within the secondary lobule by attaching them to the interlobular septa surrounding the lobule. Here we have two examples of intralobular septal thickening, asbestosis and usual interstitial pneumonia. Intralobular septal thickening may be seen as fine lines or as increased ground glass attenuation, as the intralobular septa are so fine that they often cannot be perceived as individual lines. This is especially true in the presence of fibrosis, when the lobules cannot be fully aerated. Intralobular disease may be seen in numerous conditions, such as in interstitial fibrosis, edema, and sarcoidosis. These CTs show some architectural distortion of the secondary lobules in diseases with reticular patterns. Architectural distortion occurs when fibrosis leads to localized loss of lung volume and shrinkage of the secondary lobules. In the image on the left, we see interlobular septal thickening in yellow arrows and intralobular septal thickening in purple circle, as well as traction bronchiectases in red arrows in a patient with asbestosis. In the image on the right, we see abnormal displacement of bronchial vessels, fissures, and septa, associated with volume loss in a patient with chronic hypersensitivity pneumonitis. This is an example of interlobular septal thickening in a patient with pulmonary edema compared to an example of interlobular and intralobular septal thickening in a patient with usual interstitial pneumonia. In the case of the patient with interlobular septal thickening due to pulmonary edema, the architecture of the secondary lobule is intact. There is no architectural distortion. In contrast, in the case of the patient with usual interstitial pneumonia, there is thickening of both the interlobular and the intralobular septa. The intralobular thickening can be seen as increased attenuation or ground glass and fine reticulation within the secondary lobule, and the architecture of the secondary lobule is lost. In some areas, there is some distortion likely caused by localized loss of lung volume due to scarring. Now let's discuss honeycombing. Honeycombing is another type of reticular disease. Honeycombing is defined by the presence of small cysts with thickened walls made up of fibrous tissue. These thick white lines within the secondary lobule represent destroyed and fibrotic lung tissue. This is an example of honeycombing in a patient with systemic sclerosis. Honeycomb cysts often predominate in the peripheral and subpleural lung regions. Regardless of etiology, subpleural honeycomb cysts typically occur in several contiguous layers, which can help distinguish honeycombing from paraseptal emphysema, in which subpleural cysts usually occur in a single layer. Honeycombing can be found in the late stage of various lung diseases with loss of architecture. The differential diagnosis of honeycombing includes idiopathic pulmonary fibrosis, rheumatoid arthritis, scleroderma, asbestosis, drug reactions, end-stage hypersensitivity pneumonitis, and sarcoidosis. This image is an example of bronchiectasis, signaled by the red arrow. Bronchiectasis is defined as dilation of the bronchioles. Bronchiectasis is cystic and tubular dilation of small airways associated with CT findings of fibrosis and architectural distortion. This is another example of interobular and intralobular septal thickening with architectural distortion, traction bronchiectasis, and honeycombing. The disease is lower lung predominant. This is an example of usual interstitial pneumonia or UIP. There are additional criteria for identifying UIP on CT imaging. UIP is a radiologic or histologic pattern, not a diagnosis that can be caused by a number of conditions, including asbestosis, rheumatoid arthritis, and drug reactions. When no cause is identified, the clinical disease is called idiopathic pulmonary fibrosis. Here we have an example of upper lung predominant intralobular and interlobular septal thickening with architectural distortion, traction bronchiectasis, and honeycombing in a patient with sarcoidosis. Let's review by putting together what we have learned into an approach. If there is interlobular or intralobular septal thickening without architectural distortion, then try to distinguish between smooth versus nodular septal thickening. On the other hand, if architectural distortion is present, then identify if there is significant honeycombing in a peripheral and lower lobe distribution. If this is the case, then you may be dealing with usual interstitial pneumonia, or UIP. Lastly, if there is septal thickening with architectural distortion, but honeycombing is absent, or a minor component, then we call it NSIP pattern, where there is a broad differential, and you may need a biopsy. In the next lecture, we will cover nodular patterns of disease.